resonance on the left lower zone.
Okay. So with the help of this history and examination, what are you suspecting in this case?
Progressive breathlessness, 2 weeks and left-sided cold. He's a chronic smoker. Chronic
Yeah.
smoker presented with a progressive breathlessness in an age of 55-year-old is a more suspective towards the uh, respiratory cause of shortness of breath, most
Okay.
likely to towards
What are the points in favor of respiratory cause of shortness of breath?
yes sir. So first of all, the patient is a chronic smoker, uh,
Yes.
and
No, but that can also lead to cardiovascular cause, right?
and a vocal there is a absent vocal resonance as well, along with a decreased breath sound on the left side, left lower zone of lung,
Okay.
along with a
So
history of chronic smoking.
basically, along with smoking, you will say that there is no history suggestive of cardiovascular dyspnea, like there is no history of orthopnea, there is no history of shortness of breath while lying in supine position, no history of PND. Then patient is having progressive breathlessness, not on and off. So these are
Yes,
the points in favor of respiratory dyspnea. Okay.
yes,
Also, the weight loss history is very important in this case as it will point toward a chronic infection or malignancy. Let's see what it turns out to be. Okay. So, based on the examination, what are you suspecting in respiratory dyspnea?
sir. In respiratory dyspnea, on examination there is a that as per question says ki there is a decreased breath sound or air entry or either of the lung or both lungs
Okay.
with uh, mm, any abnormal breath sound we get like bronchial or
Okay.
bronchi
So how will we?
examination. First we take a consent of the patient for examination.
No. Yeah, yeah. Very important.
Very yes sir. And we I going examine the patient in sitting position,
Okay.
and then first the steps of examination is first is to inspection.
Yes.
And while inspecting the patient, we I look for the shape of the chest,
Hmm.
uh, and shape of the chest. Hello.
Okay, so you will be
Yes.
given less time, so you have to say just like we'll go from inspection, palpation, percussion, auscultation, and briefly we'll tell what are the points for your case, each and every point for inspection, what is favoring the disease, then palpation, then percussion. So let's just move on to the X-ray of this case. By mistake, it is given as a, I think in history it is given left-sided, but on X-ray it is right-sided examination findings. So we'll approach it from right side. Okay. So what are the findings in X-ray?
Sir, there is a this X-ray is a X-ray chest PA view showing the uh, and CP angle blunted on the right side, homogeneous opacity seen. Most probably there is a uh, effusion on the right side of chest. So look like sir, it's a pleural effusion.
Okay. So can you classify the types of pleural effusion?
The classification of pleural effusion, the fluid may be exudative or transductive uh,
Yes.
as per their cause. Sir. So sir,
What all are included in exudative? What all are included in transudative? How will we differentiate based on the lights criteria? Can you explain?
yes, sir. Pleural fluid. We compare the pleural fluid as per and serum LDH is more than zero point 0.6, pleural protein or serum protein more than zero point 0.5,
Mm-hmm.
more than zero point 0.5.
Mm-hmm. or serum LDH, pleural fluid LDH is more than two-thirds of the upper limit of serum
Upper
LDH.
limit of MLDS.
Okay, if either of these is fulfilled, then we say it as exudative.
Yes, sir.
Can you list some causes of transudative pleural effusion?
Transitive pleural effusion cause congestive heart failure, nephrotic syndrome,
Okay,
and hypothyroidism, mixed edema,
okay.
and
So now, how will you approach this case? But what all investigations you will send? How will you perform the thoracocentesis in this case? Can you explain the procedure in brief?
sir, we go for the sir, to confirm the either it's a exudative or transudative. We go for pleural tap, and sir, first a pleural tap is done in eighth intercostal space
Hmm.
mid. Audible? Hello?
Hello.
Hello?
Yeah, you are audible.
Okay, sir. Sir, for pleural tap, we tapping done in the sitting position with arms bending forward and posterior side 8 intercostal space.
Okay.
Either upper border of lower rib on the lower side of intercostal space. We go
Hmm.
through a needle and we go for diagnostic as well as a therapeutic as per need. In this patient, it's a moderate pleural effusion. Look in X-ray.
Okay, so first of all, you have to say that we have to always go for USG guided thoracocentesis. Okay. Nowadays, we do not go for blind pleurocentesis or thoracocentesis.
Yes, sir. Yes,
Okay.
sir. We go
It should be
USC.
always be done under USG guidance.
Yes, sir.
Okay.
And then
So
send
what
the
all,
sample. Yes, sir.
according to this clinical case, what all samples will you send for this case?
Sir, TB is the most common in India. Uh, cause pleural effusion. So, sir, we take a sample and send for laboratory examination for ADA level and any cultures. If we suspect any infections, we go for cultures like gram culture, uh, AFB cultures.
Okay. Will you be
And
sending CB naught of this sample?
yes, sir, can send a CB not or expert. We can.
Okay, so CB naught is sensitive and specific for pleural effusion, pleural TB or not?
Sir, sir, we take a history of a TB. If patient has previous history of TB and completed their course, sir, within a 2 years of completion of their course, the sir TCB not is not sensitive. Sir, is a falsely positive in that type of patient. So we most rely on the AFB, AFB. Sir.
No, but this is not a open case of TB. This is a secondary TB. Okay, so you cannot rely on sputum CB naught for this.
Yes.
So basically, pleural fluid is not an ideal sample for CB naught. It has a sensitivity and specificity ranging in 40 to 50%. So the gold standard investigation for this case will be pleural biopsy.
Yes, sir.
But if other things are suggestive like ADA is higher, then if there is predominantly transudative effusion with lymphocytic predominance, then we can also start the anti-tubercular therapy.
Yes, sir.
Uh, while looking at the trachea in this case, do you notice any thing which is not going in favor of pleural effusion?
Sir, trachea is in midline. In pleural effusion, trachea shift towards the opposite side. In this case, pleural effusion in the right side, so trachea will be shift towards the left side,
So then
which is not.
you are saying that this is not a case of pleural effusion?
No, sir. This is the case of pleural effusion. Uh,
So can you explain the finding that trachea is in the midline instead of uh, moving towards the left side?
first is a consolidation, and in consolidation, trachea is in midline.
No,
Second
no.
is, sir,
For this case, what can be
in
the
this
reason?
case, sir, if pleural effusion on the right side, so the with opposite side fibrosis if present, then trachea is in the midline. Up,
No, not opposite side, same side.
same side. Sorry, sir, same side.
Because fibrosis will pull the trachea and pleural effusion will
And
push the trachea.
push the trachea to
Okay.
negligible.
So pleural effusion with collapse or pleural effusion with fibrosis. So
Yes, sir.
there can be a collapse of right lower lobe in this case. That's why trachea is in the midline.
Yes.
Okay. So let's move on to the next case. Dr. Depriyo, over to you.
Yeah. Hello.
Hello. Yes, we can listen you.
Yeah. A 60-year-old male, a known case of carcinoma of the kidney, diagnosed 6 months ago, presenting with progressive breathlessness, dry cough, and weight loss for the past month, arrived at OPD for breathlessness.
Okay. So let's move on to the imaging.
Yeah. Explain the chest X-ray. How to present any other clinical examination. This chest X-ray is a X-ray PA view with trachea midline, no soft tissue abnormality, and there are multiple homogeneous opacities on bilateral lung fields. Bilateral, left-sided CP angle is blunted, right-sided it is clear, and yeah.
Okay,
So
so
these
how can you mm, differentiate whether the X-ray is PA view or AP view?
In AP view, there is apparent cardiomegaly, and we also look at the clavicles.
Okay. And is it a, good inspiratory film or poor inspiratory film? How can you comment on that?
If the lower thoracic vertebrae are the borders of the lower thoracic vertebrae are just visible, then we say that the exposure is good. But here the borders are not very clear, so I would say that maybe it is overexposed.
This is about exposure, but there is something known as poor inspiration and good
Okay.
inspiration.
We count.
Why?
Yeah, we count the anterior ends of the ribs.
Okay,
Uh,
so
if it is up to six in the if the anterior ends are up to 6 to 8, then we say that it is good inspiration. Like yeah.
okay, okay, correct. So these are the well circumscribed multiple large round pulmonary metastases. What all cancers can lead to this cannonball mets?
Uh, Testicular carcinoma, colonic carcinoma,
Okay,
um,
the most common cause, which is given in the history in this case also.
is renal cell carcinoma. He
Okay,
has a history of kidney kidney mass. Yeah.
okay, okay. So, can you just tell that what can be the diagnostic approach towards this case? How will you approach this case? Further, what investigations will you order?
Uh, based on the patient's general status, first of all, I'll order some blood investigations like
Hmm.
CBC, LFT, KFT. After that, chest X-ray has already been done. Since it is a case of renal cell carcinoma, I'll look for urine examination also, routine urine examination to look for although patient will present with gross hematuria, but there can be microscopic hematuria as well. After that, I'll order since since it has since the X-ray shows cannon wall metastasis, so we can go for contrast enhanced CT of thorax. That will further confirm the diagnosis. And for places for other sites of metastasis, we can go for 18 FTG PET scan.
Okay, correct. Very good. Uh, so is there any role of biopsy in this case?
Uh, Biopsy, I don't think
Lung biopsy.
lung biopsy should not be of much value, because or we can
Patient.
suppose, yeah, in this patient, if at all we have to differentiate between uh, bronchogenic carcinoma with lung mets, then we can go for biopsy or bronchoalveolar lavage and also those sort of things. But it is from history, as it is clear that it is lung mets only, so I don't think a biopsy would be much required in this patient.
Okay, okay, correct. Okay. So these much questions will only be asked for the post-graduation level. Uh, I think we can move on to the next case. Okay, so moving to the next one.
Yes, yes. A 45-year-old male presents with progressive breathlessness for 3 months, dry cough, and weight loss. On examination, clubbing was noted in all fingers and toes. No history of fever, hemoptysis, or chest pain. He has been a chronic smoker for 20 years. And
Okay. So what is the finding in this case?
um, the uh, uh, there is clubbing and the uh, with breathlessness and respiratory pathology. So, uh, uh, mm,
Anything else you can comment other than clubbing, seeing the fingernails of this patient?
pallor is there. Uh,
No, pallor is not an ideal site for these fingernails to see,
um,
as the skin is almost like
okay.
erythematous. We can clearly
Yes.
see cyanosis also, right?
Yeah.
Bluish
Yeah.
tinge to the nails.
Yes.
Okay.
Uh,
So, how do you define clubbing and what is its grading system? How do you grade
I
clubbing?
se- for confirming the clubbing, I will go for Samroth window. I will uh, go for
Okay.
and for grading. There is grade one is softness of nail bed. Grade two is obliteration of low bond angle. Grade three is parrot beak appearance. Grade four is hypertrophic um, HOA
Osteoarthropathy.
osteoarthropathy.
Okay.
Yes.
So, what is Shamroad test?
Uh, I uh, I can only show, but I cannot maybe describe. Um,
No.
two
What would
fingers are
you?
first.
Yeah.
Two fingers are jointed simultaneously, and the middle window is we have to see through. If it is obliterated, then we can say there is a clubbing.
Okay. So, what is the name of the angle which we see uh, on the
Angle is low
fingernail?
bond angle, and if we see our window, then it is a Semroth window.
Okay. What is the normal angle?
I I cannot remember, sir.
Okay. So, normally the angle between the finger nail and nail bed is around 160 degree, less than 180 degree will be all right. But if the angle is more than 180 degree, it is suggestive of clubbing.
Okay, sir.
Okay. And in Shamrod test, we are looking for the diamond shaped window between the
Yes,
two
sir.
index fingers. If it is
Yes.
forming, then it is normal. If the window is obliterated, the diamond is not formed, then it is positive Shamrod test, which is suggestive of club. Okay.
Yes.
So, can you name some causes for differential clubbing? What is differential clubbing?
Mm. One hand will have clubbing and the other won't.
Okay.
But sir, I'm not sure about the causes. So.
Okay. And what about the lower limbs clubbing without upper limb clubbing? Can you name some causes?
Sorry, sir.
Okay, so just read it from the book. These are the
Sure.
potential MCQs in the exams. Okay, so lower limb
Yes.
clubbing can be seen with coarctation of aorta, and differential clubbing can be seen with PDA and some other cyanotic congenital heart diseases. Uh, what is the criteria for cyanosis to occur?
Mhm. Criteria.
Means reduced hemoglobin should be more than what level so as to manifest as cyanosis.
I'm not aware, sir.
Okay. So if the reduced hemoglobin concentration, if the reduced hemoglobin concentration is more than 4 grams per deciliter, then cyanosis can manifest. That is
Okay,
the
sir.
reason why polycythemia patients are more often cyanosed as compared to anemic patients. Since anemic patients will have limited hemoglobin, so it is very less likely that reduced hemoglobin concentrations will go over 4 gram per deciliter. Then you
Yes.
must know the mechanism for central as well as peripheral cyanosis. What are the sites to look for central cyanosis? What are the sites to look for peripheral cyanosis? How can you differentiate between central and cyanosis based on this figure? So, central cyanosis can affect central sites like tongue, lips,
Yes.
as well as peripheral sites. But peripheral cyanosis will only affect the peripheral sites. So we'll just rub the finger of the patient. If after rubbing, giving heat to the patient, if the cyanosis is getting recovered, it is peripheral cyanosis, but in central cause, it will not get recovered.
Yes.
So these questions should be uh, thought to be asked in the exam. Okay, so
Okay.
moving on to the next case.
Okay, sir.
Hello. Okay. A 58-year-old male presented with acute onset chest pain radiating to the left arm for the past 2 hours. The pain is describing as squeezing associated with diaphoresis, nausea, and mild breathlessness. No prior history of cardiac illness. He is a chronic smoker with 30 pack year history and has poorly controlled hypertension.
Okay, please
And
comment on the ECG.
there is a 12 lead ECG which is in sinus rhythm with rate of rate of almost
Around 80 to 90.
80 to 90 per minute, and rhythm is regular, and the specific changes there is ST segment elevation is seen in the chest lead of V2, V3, V4, and V5.
Hmm.
Mm, So it it is a probably the patient is presented with the acute coronary syndrome, STEMI of anteroseptal valve, and also V1 is also elevated. V1 ST segment is also elevated.
Hmm. So basically, this is extensive anterior volume.
Extensive anterior valve. Yes.
Okay, so anterior segment V1, V2, then V3,
Mm.
V4, and elevations can be seen up to V5 level.
Mhm.
Okay, can you notice some reciprocal depressions?
Reciprocal depression in uh, lead 3, lead 2, and AVS.
No, AVL will be showing elevation since it is anterolateral.
AVF.
1 and AVL are also showing elevation. So it is extensive anterolateral MI, and grade 3 and AVF is showing reciprocal depression. Okay, so it is a confirmed case of ST elevation MI. So suppose there is no reciprocal depressions in this ECG, and
Yeah.
ST elevation is not up to the mark as seen in this. There is slight ST elevation. So what can be the closest possibility?
Maybe this may be the posterior wall MI, or maybe the right ventricular wall MI. So
No,
we
ST
could
elevation is, and ST elevation is generalized ST elevation in all the leads. So what will be the differential diagnosis?
generalized ST elevation, if there, that can be due to maybe a post MI pericarditis, or
Okay.
in acute setting maybe, or
Okay, most common causes acute viral pericarditis or acute pericarditis, we'll say like that.
pericarditis.
And there will be concave up ST elevation in acute pericarditis, while
Yeah.
here it is
It is coving of the ST segment.
coving of ST segment. Okay. So once this ECG is with you, how will you then approach with the patient?
So first I will, if the clinical sign and the ECG is confirming and the patient is presented within 2 hours, so the necrosis marker like TROP-T or HS TROP-I will not be positive. So I will start with
Okay,
the cardiac load.
is TROP-T, TROP-I required for this case to start for the therapy?
No, clinical sign and ECG is suggesting that. That means
Okay,
it is
so
diagnosed case.
as in ST elevation MI, there is no role to do TROP-T or TROP-I. It is just to
Yeah.
confirm unstable angina versus non-ST elevation MI. Okay,
Okay. Okay.
we can directly proceed with the thrombolysis or CAG, whatever
This
facility is
is
available.
level, yes.
Okay, can you tell about the blood supply of the heart? What are the various arteries and which territory these supply?
Blood supply of heart, arterial supply is through the coronary artery, right and left coronary artery, and right coronary artery supply the right side of the heart up to the right atrium and right ventricle, and, and left coronary artery gives the left main coronary artery, and then left anterior descending and left circumflex artery, and
Okay, correct. So, and what is the normally which artery supplies the SA node and which supplies the AV node?
SA node is supplied by the right coronary artery,
Okay.
and AV node is supplied by the left circumflex. Maybe I am not that aware.
Most of the times it is again supplied by the right coronary artery in 60% cases. Okay. So, what can be the various complications in this case?
Complication, maybe acute acute MR may be a complication, maybe arrhythmia, maybe ventricular free wall rupture, and maybe may
So,
lead to heart failure.
complications you will divide as much as possible, divide your answer into and categorize your answer. So, you can say like
Okay.
early complications and delayed complications. So it
Okay.
will uh, give a better frame to your answer. Okay. So we can have
Okay.
early complications, then we can have complications after 2 to 4 days, then after weeks. So you can divide uh, like this.
Okay. Okay.
Okay. What is Dressler syndrome?
Dressler syndrome is post-MI pericarditis.
After how much time? Uh, if the
Within
pericarditis is occurring?
within 48 hours.
Dressler syndrome usually occurs after, is it 48 hours?
I am not sure.
Okay. Okay, so there are two types of pericarditis which can occur after acute MI. First one is post MI pericarditis, which usually occurs after 2 to 3 days, which you are telling. But Dressler syndrome, which is an autoimmune phenomenon, it usually occurs after 4 to 6 weeks. Okay. And this needs
Okay.
to be treated with anti-inflammatory drugs as well as steroids.
Okay.
Okay. So, uh, how will you thrombolyze this patient?
Thrombolyze with the help of recombinant tissue plasminogen activator like tenecteplase
Okay.
or
Do we
streptokinase.
prefer uh, tissue plasminogen activators over and above streptokinase or urokinase?
Uh, yes, we prefer, but there is because they are fibrin specific. That's why we prefer.
Okay. Okay. So I think more than sufficient for this case. Let's move on to the next one.
Yes, sir. A 70-year-old male presents with complaint of intermittent dizziness, palpitations, and near syncope episode for 3 days. He has a history of ischemic heart disease and hypertension, but no prior history of arrhythmias. He reports no chest pain or dyspnea. Mm, mm, this is ECG showing mm, AV dissociation with irregular RR intervals. Complaining of intermittent dizziness, palpitation, and near syncope episode for 3 days. So patient is having possibility of complete heart block.
Is it complete heart block?
Mm, no, sir. Second degree heart block. Type 2
Okay.
morbid second degree heart block.
Okay, correct. So, what are the features of various types of heart block?
Sir,
First degree, second degree, third degree.
in case of first degree heart block, there is an increase in PR interval, but no skippage of uh, no skippage of heartbeat in between. And in case
Okay.
of second degree heart block, there are two types, type 1 and type 2. In case of type 1, PR interval will increase successively, and
Okay.
after 2 or 3 beats, there is missing of one beat. In case
Correct.
of type 2 type 2 morbid's heart block, their PR interval is fixed,
Hmm.
and there is a skippage of heartbeat in between, and there is 2 is to 1 conduction or 3 is to 1 conduction is there. And
Correct.
in case of third degree heart block, there is a complete AV dissociation will be there.
Yeah.
And
And will it
yes,
affect QRS?
no, it will not affect QRS.
Third degree heart block.
uh, there maybe 2 is to 1, 3 is to 1, or 4 is to 1 dissociation
In
will be there.
in in complete heart block, since there is hmm, nothing which can pass from the atria to ventricles, now the
So
ventricles
QRS
will
interval
generate their
will
rhythm.
be prolonged. QRS can be prolonged.
QRS will be wide.
Yes, sir.
It can be narrow as well, wide. If the
Yes,
origin
sir.
of the ventricular rhythm is from or near the bundle of his, the QRS will be narrow. If it is from
Yes,
left
sir.
or right ventricle, there will be widening of QRS. Correct.
Yes, sir. Yes, sir.
So in this ECG, what are you suspecting? Type 1 Mobitz or Mobitz type 2?
Mm, type 2, sir. As
Why
PR
type 2?
interval is fixed. PR interval is fixed, sir.
If you see the fifth QRS complex
Yes, sir.
and you see the fourth QRS complex,
Ji, sir.
so there is slight difference in PR interval, I think.
After fourth QRS, sir, there is missing of one beat. But PR interval is between like fourth P and QR is long, fifth PR interval is short, sir.
No, after fourth there is missing. Before the fourth, the PR interval, if you count the blocks,
Yes, जी sir.
there are around 11 to 12 blocks. And before the fifth QRS, there are only 8 to 9 blocks. So there is gradual prolongation of PR interval in this case. You can also
Okay,
compare
sir.
between the first QRS and fourth QRS. By seeing only, we can see that
Yes, sir. Yes,
first
sir.
PRL is shorter than the fourth
जी
QRS.
sir.
So
Yes,
it will
sir.
be Mobitz type 1. Okay.
जी sir. Okay, sir.
So is there any difference we are creating for the patient so as to grade it into Mobitz type 1 or Mobitz type 2 or complete heart block? Will it differ? There will be difference in management or what?
Yes, sir. Type 1, in case of complete heart block, as if there are reversible causes, then we can plan for a temporary pacemaker will be the management plan. And if
Okay.
irreversible causes, then permanent pacemaker should be inserted. And in case of type 1 type 2 morbid heart block also, it can progress to complete heart block.
Okay.
So temporary pacemaker will be option for that.
Yeah. So pacing will be required in each and every case of complete heart block as well as Mobitz type 2 heart block. While we can
Yes,
observe
sir.
the cases of Mobitz type 1 as these
Yes,
can
sir.
recover on its own also. Okay.
Yes, sir. Ji, sir.
Can you name some list some causes of heart block other than myocardial infarction?
In case of hyperkalemia, there can be heart block, severe
Okay.
hyperkalemia, and in case
Okay.
of
So
infiltrative,
yeah, you will
yes, sir.
classify the causes like electrolyte disturbances, infiltrations,
Yes,
then
sir.
infections, likewise
Yes, sir.
ischemic causes, vascular causes. So always try to classify the answer.
Okay, sir. Yes, sir. In
Okay.
case of electrolyte imbalance due to hyperkalemia, also due to severe hypercalcemia also,
Correct.
and in case of infiltrative disorder like amyloidosis,
Hmm.
glycogen storage disorders, and in case of metabolic like hypothyroidism, myxedema coma,
Correct. Okay.
due to some drugs also.
So what is the cause of uh, block in this case?
As patient have a previous history of ischemic heart disease,
So which territory involvement will likely lead to block, and which territory will lead to increased heart rate in MI patients?
in case of heart block, uh, RC territory will
Hmm.
increase
Correct. So inferior wall
node
MI
as
due to
well as AV node.
yeah, RC territory will lead to
Inferior
uh,
wall MI, yes sir. जी sir,
correct.
inferior or
And
RVMI along with.
okay, and anterior wall MI is associated with increased heart rate during MI.
Yes sir.
Okay, as it will disrupt the
जी sir.
supply of parasympathetic system, so sympathetic overactivity will occur.
Yes sir.
Okay, so let's move on to the next case.
Okay sir.
Yes, sir. Sir, a 45-year-old female present with progressive joint deformities of both hands, uh, associated with a pain, stiffness, and difficulty performing daily activity over the past 10 years.
So what all deformities can you see in this case?
I'm not able to explain, sir. Sir,
Okay,
actually,
so what is the diagnosis? Can you
sir,
diagnose
a
this case?
45-year-old female with, sir, uh, Sir, actually, this deformity is associated with a pain and stiffness in a 45-year-old female. Uh, Sir, we in clinical scenario we suspect RA, but sir,
Okay.
joint deformities.
This image itself is diagnostic of RA. No confusion.
Yes, sir.
Okay.
Swan neck deformities and Botneso deformity. And these two deformities.
Okay. So what is swan neck deformity?
Swan neck deformity is a hyper uh, flexion of PIP and extension of DIP.
This will be
उल्टा बोल
buttonose
दिया
deformity.
yes sir.
हाँ, ठीक है, ठीक है। ये जो आपने बताया ये buttonose deformity है।
Botneso sir इसका flexion at DIP and flexion at DIP and extension at PIP is swan neck and vice versa.
Correct, correct, correct. Okay, so any other deformities you can name in RA?
Sir, jet deformity and sir, ulnar deviation of the hand maybe.
Okay. So is there any deformity which is reversible?
Sorry sir.
Okay, so piano key deformity and hitchhiker's thumbs are reversible deformities in RA which can be reversed with therapy. Okay, rest all of the deformities are irreversible.
Okay sir.
Can you name some extra articular manifestations of RA?
Sir, extraarticular manifestation of RA, sir, sir, intestine is associated with IBD, sir, ocular, it is associated with the anterior uveitis or scleritis, sir, EP
Anterior
scleritis or
uveitis.
scleritis, EP scleritis, sir, nodular,
Anterior
EP,
uveitis is against the
sir,
diagnosis for RA.
yes,
Okay.
sir, EP
Then
scleritis,
correct.
and sir, IBD,
Then what is
inflammatory bowel
Felty's
disease,
syndrome? What is
Felty
Felty's
syndrome,
syndrome?
sir, rheumatoid arthritis with neutropenia. Uh, and sir, splenic enlargement combination is a fatigue syndrome.
Okay. Okay. Then what are the antibodies which will you test in this patient?
Sir, in rheumatoid arthritis, we look for anti-CCP, sir.
Okay, which one is more
Antibodies,
specific? Which one is more specific, RA factor or anti-CCP?
sir, more specific is anti-CCP. RA factor is a sensitive and
Okay. Okay. Suppose anti-CCP is positive, RA factor is positive, ESR is elevated, CRP is elevated. How will you treat this patient?
sir, first of all, first of all, sir, we start with the NSAIDs with uh, methotrexate, sir.
Okay.
DMRD, sir, methotrexate, sir. Start करते हैं, sir.
Okay. Correct. What all biologicals can be used?
Sir, biological, sir, TNF alpha inhibitors, interleukins inhibitors,
Can you
etanercept.
name each category drugs, each biological category drugs? Can you give one examples?
Sir, TNF TNF1 alpha inhibitors, sir, infliximab and
Correct.
uh, some uh, enakinara and
No, anakinra is not TNF alpha.
sir, actually I'm confusing in the drug.
Okay, so just read this from the textbook. This can be a potential question.
Yes, sir. Yes, sir.
Okay. Let's move on to the next case. Let's move on to the icterus case.
A 42-year-old male presents with yellowish discoloration of the eyes and skin for 10 days. And the image is showing uh, upper eyelid exposing. There is a yellowish sclera, so mostly jaundice.
Okay, so what is difference between icterus and jaundice?
Icterus means there is a uh,
This is a case of
involvement.
jaundice or icterus?
Icterus. Uh,
Okay.
uh, uh,
Hmm. What can be the various causes of icterus?
there in any liver disease like cirrhosis, hepatitis, and uh, Wilson's disease.
Okay, so you are telling the causes of jaundice. But
Okay.
if we are talking about icterus, it is just yellowish discoloration of sclera. Okay,
Okay.
so it can be due to jaundice or causes other than jaundice, like ingestion of carrot,
Okay.
then increased vitamin A intake. These all can be the causes of yellowish discoloration.
Okay.
Okay, so now you can tell the causes of jaundice. Basically, you can classify jaundice in
Uh,
prehepatic, hepatic, and posthepatic.
yes. Uh, uh, the, Post hepatic means obstructive jaundice
Correct.
because of any obstruction in the biliary drainage system. Hepatic jaundice can be from a viral hepatitis. Uh, it also and any intrinsic liver disease. Prehepatic jaundice can be from hemolysis, hemolytic anemia, and uh,
Okay, so by looking at the serum bilirubin report, indirect bilirubin and direct bilirubin, can you comment
yes,
on the cause of jaundice?
yes, because in prehepatic there will in obstructive there will be conjugated hyperbilirubinemia, means direct bilirubin is elevated, and
Direct
in
bilirubin at up to what level? That means out of total bilirubin, how much should be the direct bilirubin to say it as obstructive?
I cannot remember, sir.
Okay, so for indirect hyperbilirubinemia means if there is hemolytic jaundice, indirect bilirubin should be more than 85% of total, means direct should be less than 15%.
Yes,
For hepatic jaundice, direct should be from 15 to 50%. Okay,
yes,
and if the direct bilirubin is more than 50% of the total, then it is most likely a obstructive cause, a
obstructive.
post-hepatic cause.
Yes,
Okay, so can you name some causes uh, of jaundice without any elevation in transaminases of liver, without any elevation of AST, ALT? The patient is coming with jaundice. What can be the differential diagnosis if it is indirect hyperbilirubinemia or direct hyperbilirubinemia?
not sure, sir.
No, I mean to say, for example, if there is viral hepatitis, so the
Okay.
AST, ALT will also increase along with serum bilirubin. If it is
Yes,
chronic liver disease, there will be other abnormalities. AST, ALT, albumin will change. If it
yes,
is
sir.
obstructive jaundice, also there will be slight elevation of AST, ALT. But is
Yes,
there
sir.
any condition in which there is only rise in bilirubin without any rise in AST, ALT, without any rise in GGT? Have you heard of Gilbert syndrome, Dubin-Johnson syndrome,
Yes, sir. Yes,
Rotor syndrome, Krigler-Najar? So how will you classify these? Okay, so if there is indirect hyperbilirubinemia, this can be due to hemolytic anemia, then due to some drugs like rifampicin, probenecid, due to inherited conditions like Gilbert syndrome, Crigler-Najjar. And if we have direct hyperbilirubinemia, this can be due to inherited conditions like Dubin-Johnson and Rotor syndrome. So this you have
Okay.
to study for your exams.
Yes, sir.
This can be a potential question if you see a case of jaundice.
Yes, sir.
Okay, rest CLD viral hepatitis you must be knowing.
Yes, sir.
Okay, so let's move on to the next case. I think that's the last case, Dr. Depriyo. Okay, okay,
Yes, sir. A 35-year-old male presents with fever, productive cough with rust-colored sputum, and pleuritic chest pain for 5 days. He also reports malaise and dyspnea on exertion. No history of tuberculosis, smoking, or significant comorbidities. On examination, he has a high-grade fever, tachypnea, reduced breath sound, and coarse crepitations in the right upper chest. Right upper chest. Okay. So, according to
is there any
history, like
X-ray?
fever.
Yeah, okay,
This is the chest X-ray PA view with the homogeneous opacity in the right upper lung zone. And according to history also, possibility of right upper lobe pneumonia. Consider right.
okay. So what are the various clinical findings you will see in this case?
On inspection, decreased movements on the right upper lung zone, and
Correct.
on palpation also, we will confirm the decreased movement by palpatory method. And on percussion, there is a dull note on percussion on the right upper lung zone in the
You
supraclavicular
will
as well as
you will
infraclavicular.
yeah, you will also measure it through a tape, right? In
Measuring
palpation.
tape, yes, sir.
Hmm.
Ji, sir. And on percussion, dull note will be present in the supraclavicular, infraclavicular, and interscapular area as well as suprascapular area. And on auscultation, bronchial breath sound may present along with whispering pectoralici, agophony, and increased vocal
Good.
resonance also will be there. And also percussion vocal fremitus is also increased.
Great. Very good. So how can you differentiate this with collapse on this X-ray?
In case of collapse, trachea will be shifted toward the right side, and also breath sounds are also decreased, but vocal resonance will not increase in case of collapse. And also vocal fremitus is also decreased in case of collapse.
And what will be in the percussion?
In percussion, impaired note will be there in case of collapse.
Correct, 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 correct. So impaired note is characteristic of collapse, and dull note is characteristic of consolidation. We don't know what is the basic difference when we hear these, but examiners are fond of listing the impaired note on collapse. Okay.
Yes, sir.
So, can you name the various stages of uh, pneumonia, pathological
Uh,
stages?
yes, sir. There are four stages.
Okay,
Um, I am not able to remember first stage, but second is red hepatization, third one is gray hepatization, and fourth one is resolution phase.
okay. First one is anyone else can answer?
First,
Okay.
consolidation phase. Yes, sir.
First stage is stage of congestion. Okay,
Congestion. Okay.
okay. So, what can be the etiology in this case? Since it is a short
Yes.
history and it is a community acquired pneumonia, what can be the various bacteria causing community
The
acquired pneumonia?
streptococcal pneumonia, Klebsiella, Staph aureus, and in case of like underlying lung disease, then patient may also have Pseudomonas aeruginosa, Haemophilus influenza.
Okay. So how will you start the antibiotics? The patient is coming on to you. First of all, tell me what is the curve scoring, curve 65 scoring.
According to curve 65 score, like C is for confusion and U is blood urea nitrogen greater than 22 milligram per deciliter and respiratory rate more than 22 and blood pressure systolic blood pressure is if less than 90 or diastolic blood pressure is less than 60 and age of patient is 65 more than 65.
Okay.
And then on the basis of score we will decide whether to start antibiotics on the OPD basis or whether we want to admit the patient or not. If score is 0 we can start antibiotics on the basis of OPD basis, and if score is 1 or 2 then in case of score 1 we can observe the patient, and if score is 2
Correct,
or more
correct,
than
correct,
2 we
correct.
can admit the patient.
So, what is the score in this case? Dr. Dev, can you please uh, shift the slide to the history of the case?
Like patient is 35-year-old male with as patient is having tachypnea,
Hmm.
so only score 1 will be there.
Okay.
Yes sir.
So we can basically manage this case if the tachypnea is only slight tachypnea rate is 20-22. We can
Yes
manage
sir.
this patient very well in the OPD. So what will be
Yes
the
sir.
antibiotic therapy for this case if you are managing this in OPD?
As patient have no underlying comorbidity and no risk factors for antibiotic resistance are there, so we can simply start we can give macrolides like azithromycin or only doxycycline. Macrolide azithromycin 500 milligram on day 1 and 250 milligram for 4 days, and doxycycline 100 milligram BD for 5 days. Or
Is it the
simply,
guideline which is given in Harrison?
yes sir, if there are no risk factors present for or no comorbidities are there.
If there are no risk factors present or no comorbidity there, then also we have to start with amoxicillin plus either a macrolide or doxycycline, I guess.
Yes sir, yes. Ji sir.
Currently, there is no role of monotherapy.
Okay sir, yes sir.
And if there is any comorbidity diabetes, then we will convert into amoxiclav,
Ji sir, yes
if I
sir.
am
Or
right.
plain
So,
levofloxacin we can also give.
yeah. So,
Yes.
basically, just read the guidelines from
Okay
Harrison.
sir.
It is
Ji
given
sir.
beautifully in Harrison.
Okay sir.
Currently, there is no role of monotherapy with azithromycin or doxycycline.
Okay sir.
Okay, so I think we have covered most of the cases. And
Okay.
short viva will be like this only. Long cases, I think you are covering one case each day on the YouTube channel.
Okay sir. Thank you sir.
Okay, thank you so much. Thank you.